on this patient. So we did this in a full general anesthesia. Both sides, especially in the femoral vein, were included in this patient post-IV drug abuse. Of course, he's now not any longer dependent, of course. We concentrated by this time on the right side. And I want to show you the situation we usually face in these patients. You can see this totally destroyed right groin in a patient. And the question, of course, now is how to penetrate such an occlusion in an area where definitely no more vein exists, only scar tissue is present, post infection of this groin. So the question is how to penetrate, find a track, foxhole track here to penetrate. What we are using here is a 10 French access sheet. We have here a support catheter. As you can see, this is called the Triforce system from Cook Medical. This is a mother and child technique. You can see here the support catheter, which is then again supported by Navicross itself. And within this mother and child situation, we then were able to get an Advantage 18 wire through this very diseased area here in the right groin. Luckily, the external proximal part, the common iliac vein part, was patent in this patient. So the next step, of course, is to force a more robust support catheter through this occlusion, exchange then to a support wire. We typically use the Amplatz superstrip wire, which we then use for pre-dilatation and upsize dilatation to create a channel where we at last step are able to implant a stent. You can see here we started with very small balloons. This is just a 4mm balloon, no larger balloon, followed actually this support wire. So we started just a little bit to create a channel here with a 4mm balloon. A lot of balloons actually ruptured here, but we were able to size this up using this just step-up balloon technology here. And then by time after 6 and 8mm, we were then able to forward an Atlas gold balloon here. As you can see here, and what you can nicely see is the dog boning here of this balloon. This is a 12mm Atlas gold balloon. In the middle, you see this dog boning because of the severe scar compression in this tight stenosis and tight occlusion. So what I typically do is I inflate this balloon every second minute, starting with 2 atmospheres, then 4, 6, 8 atmospheres. Let the balloon work a little bit over a couple of minutes, and with this, you are able to at least create a certain channel. The question, of course, is then what is the next step? Here, the next step for us was then to use a 40mm balloon before we then go for final stent implantation. You can see here that we were able to create this channel. You can see that this is, of course, not a significant lumen which we created here, maybe around 6-8mm after using a 40mm Atlas Gold balloon. Of course, an Atlas Gold balloon is not able to be ruptured. This is a very good balloon for this scenario. For me, typically, the only stent solution in this area is a braided stent design. In this case, we used the Blue Flow dedicated venous stent here. I will stop this for a second. This is a handmade braided stent, which comes in sizes from 10 to 16mm in different lengths, up to 150mm. This here is a 14 100mm stent, 10 French system, running over an 035 guide wire. What is very important here is that you use a push and pin technique to really push this stent as a braided stent into this scar lumen. Yeah, so this is very important, and as you can see on the left video, how we do it is someone holds this stent tight at the sheath entrance, and at the back end of this stent delivery system, I really push this stent forward into this created lumen. Of course, there's a little bit compression here still there. So at the end, you have to post-dilate this here with a 40 millimeter balloon. We did this again over a couple of minutes just to create and maintain this lumen here with the 40 millimeter balloon. And in the final angio, you can nicely see here now that we created the lumen. All collaterals were gone. Good inflow, good outflow. As you could see here, and of course the iliac veins were so far patent and patent and kept patent. The anticoagulation regimen after this stent implantation for us is typically long-term anticoagulation with DOACs and NOACs. We typically prescribe apixaban 5 milligram twice a day for a minimum of 2 years, and then we step down to apixaban 2.5 milligram twice a day. Thank you very much for your attention.
Michael, great. Thank you very much. That's a very good case. I guess probably we can take a couple of questions because, yes, please, you can come to the mic. So, Michael, we have a couple of questions from the audience.
Hi, Michael. Great case. My question is, what's the patency of these stents crossing the inguinal ligament?
Yeah, very important question. Thank you very much for this. So what we did in the past, we performed a head-to-head comparison study together with the colleagues from Zurich. The Arnsberg-Zurich registry was performed comparing standard laser cut nitinol stent versus braided stent in common femoral vein disease. Of course, not only IV drug abuse, but post-thrombotic patients. And what we found was a significant higher and better patency rate for the braided stent than for the laser cut nitinol stent. And we especially analyzed stent fracture rate within the braided nitinol stent group was 0, whereas we had some stent fractures in the laser cut nitinol stent. Secondary patency was not different. The primary patency was the biggest and significant different for this patient. So for me personally, what I do in these patients with post-thrombotic syndrome, I implant proximal a standard laser cut nitinol stent these days, and then as an extension stent, I typically implant until the common femoral vein braided nitinol stent. This was published 2 years ago in the VASA journal. There you can read this full cohort analysis.
Ahmed, do you have a question? Sorry, Michael, just another question, if you don't mind.
Sure.
Hi, Michael. This is Ahmed Gawish speaking. Very nice case. I wanted to ask you about how do you plan ahead? Because obviously this was a short segment. In those cases, these are very, very fibrotic segments of the veins. How do you decide that you would intervene in such cases in terms of the indication, in terms of the patient symptoms, and also in terms of the lesion itself?
Yeah, important question. Thank you, Amin. So this was a C5 patient, already had some infection, ulceration in the past. So the indication is to be clear in these PTS patients, especially after groin injection. What we typically do as a pre-diagnostic scenario, we do perform MRV, and especially if the groin is involved, then we duplex ultrasound. What we typically don't see in these patients, there is no vein left. You know, I'm not a vascular surgeon. You probably know much better than me. There's nothing. This is just scar tissue. This is post-infection tissue. So you need to have a good radial force here to keep such compression from outside with scar tissue really patent over time. Preparation is super important. Access is super important. What we typically do in these cases, if we are not able to cross this antegrade with an antegrade access, we then perform a retrograde access or transjugular access. This has always to be prepared before we start such a case. And what is also important are the proximal iliacs also involved, or even the IVC involved. So pre-diagnostic is super, super important so that you're not ending in a catastrophe at the end.
Last question before you leave, Michael.
Thank you very much for this nice case presentation. But sometimes we facing a lot of cases of post-addiction venous occlusion in the iliac vein. How you can decide if this ligated or it is a thrombosed occlusion? Because sometimes this patient coming with infection and do ligation of the external iliac vein.
Yeah, of course, a ligation may be a scenario, but you can penetrate these kind of ligations also with sharp recanalization. We typically sometimes use also sharp recanalization like a BBAC catheter or even a TIPS needle to come across such a 2-3 centimeter ligation area. So this is possible, I think, with dedicated devices. New devices will come to the market very soon. And especially with sharp recanalization, it is possible even to penetrate such ligated veins here in this groin.
Excellent. Thank you very much, Michael. Excellent.